So I'm Rich Furi. I'm the head of rheumatology at Northwell. My passion is actually taking care of patients with lupus and doing clinical research in that area. In fact, I just got back from Australia where the World Lupus Congress was held. Is that in focus? Here we go. Okay, next slide. All right, so this is what we'll go through, and we can skip to the next slide. So as you've heard, it's really the prototypic autoimmune disease. The immune system, for whatever reason, goes a little haywire, and in addition to still providing some protective function, it starts attacking the body. And in lupus, any organ can be attacked. It typically affects young women, and and it's incredibly heterogeneous. Here are two cases that are kind of polar opposites. So the first case is a 22-year-old white female with fatigue, a malar rash. When we talk about malar rash, that's the classic butterfly rash. Joint pains, adenopathy, the ANA that you just heard of, and a little bit more on that later. And she has yet another antibody, and she's better with just taking some Motrin or whatever, and hydroxychloroquine. And hydroxychloroquine is the generic name for Plaquenil. It's an anti-malarial drug. And the dogma is now that every lupus patient should be on hydroxychloroquine for several reasons. So that patient has a good outcome. The bottom case is a same age, 22-year-old female. She's African American. She has fatigue, hair loss, scarring rash, a different kind of rash. It's discoid lupus, which has a predilection for the scalp and the ears. She's hypertensive. She has arthritis. She has kidney involvement. Has autoantibodies, a little different than the first case. She's anemic, thrombocytopenic, and despite receiving high doses of steroids and mycophenolate mofetil, an immunosuppressive, her kidneys fail and she goes on dialysis. So we have the whole spectrum from patients who have very mild disease to patients who have life-threatening disease. Next slide. What about the epidemiology? Well, as you heard, it's more of a female disease, and the ratio is about 10-to-1, females to males. And it's more prevalent in certain races. So in African Americans, in Hispanics, in Asians, the disease is more common and it's more serious. As far as mortality rates, it's actually higher in males, even though the prevalence in males is lower, but the males tend to get very sick. All right, next slide. All right, little refresher on the immune system. This may be more than what you want, but the immune system can be divided into two types. There's the innate immune system, which I have listed on the left and all the characteristics, and on the right, the adaptive immune system. But it's really interesting because the innate immune system is ancient. It's actually found in all, not only animal life, but plant life as well. So we're talking about very primitive defense system that it's not very sophisticated. There's an immediate response to something, and there's no memory. It's not sustained at all. Whereas if you move over to the right, the adaptive immune system is found in vertebrates only. And it's very sophisticated. And you've heard some of the components of the immune system. So B cells and T cells, they're very sophisticated types of cells. They have a memory, and there is some interaction between the two sides, the innate and the adaptive immune system. All right, next slide. So if we put this all together, this is a rather simplistic rendition of the pathogenesis of lupus. So the current thinking about lupus, and for that matter many autoimmune diseases, there's a genetic predisposition. And we're not talking about a single gene, we're talking about a whole network of genes, and the geneticists are still figuring that out. So Dr. Gregerson is a colleague of mine up at Northwell, and he's been working in the area of rheumatoid arthritis, but he's also touched on lupus as well. So I don't know how many genes we're up to. It's over 100 genes. So it's not like brown eyes, blue eyes. Anyway, so there's a genetic susceptibility, and then as we heard, there has to be some kind of environmental trigger to trigger this disease. And we don't know what that trigger is. For some, it actually may be smoking. We know that's a risk factor in rheumatoid arthritis, and it seems to be for lupus as well. So in this cartoon, I have the adaptive immune system on the lower left, and some of the components there. You see B cells and T cells and plasma cells. And on the top right, components of the innate immune system. So this is an animated slide. I hope it works on your Mac, on your Apple. So click again. Yeah. All right, so we'll start with a cell type called the plasmacytoid dendritic cell. And we all have these cells. But in lupus, these cells are more abundant, and they seem to migrate to certain organs. Click it again. So in my cartoon, I have the sun as the instigator. And for certain patients, the sun actually causes flares. It's the ultraviolet light. Click again. Beaming down on the skin, causing apoptosis. I know that was on your, I think that was on your vocabulary list, which is basically a fancy term for cell death. So it causes skin cells to die, and the cells release their contents. And there's RNA and there's DNA in those cells. And that debris, the DNA, for example, can enter into that cell, and it binds a receptor called TLR9, toll-like receptor 9, which was actually discovered in fruit flies. And the consequence of that interaction, click again, is the elaboration of a lot of proteins. And all these proteins are pro-inflammatory. And the chief protein is interferon alpha. And interferon alpha stimulates a whole bunch of other cells to cause inflammation. So in lupus, most patients, the majority of patients, have an overactive interferon pathway. Now, we all have interferon in our bodies. We need interferons to fight viral infections, to provide surveillance for cancer. But in lupus, it's way overactive. So one of the strategies for treating lupus, at least in development, is to subdue the interferon pathway. And you can click again. Keep going. Then we can cross over to the adaptive immune system, and these cells are overactive. That's a T cell being stimulated by a cell called a myeloid dendritic cell. Click again. Keep going. Click. And T cells and B cells talk to each other. Again, we all have T cells and we all have B cells. And a perfect example of how they interact, when you go get your flu shot, you need B cell, T cell interaction, and all these different proteins, keep clicking, between them for the B cells to make the antibodies that provide protection. Now the problem in lupus is that this system is overactive, and the B cells are making antibodies that attack the body. Keep going. And B cells rely on certain proteins. One is APRIL, the other is BLyS, B lymphocyte stimulator, for survival. That's kind of their food. And another strategy for treating lupus is to get rid of the B cells or subdue the B cells by either starving them of those growth factors or just trying to delete those B cells from the body. And B cells, click again, can turn into plasma cells, and plasma cells are factories for antibodies, and in the case of lupus, these autoantibodies. So there you see an autoantibody made by that plasma cell. It happens to be an antibody against DNA, and that's the hallmark of lupus. Normal people do not make antibodies against themselves, and they certainly don't make antibodies against DNA. But in lupus, about 50% of the patients will make anti-DNA antibodies. So you have the antibody here in red, it's binding to DNA. These complexes also can cause inflammation by click again, by activating a system called the complement system, which in turn attracts yet other types of cells in that can do damage. The neutrophil and the macrophage. So there's this big cascade effect. All right, next. Click again. And this whole system can start over again. Click it. Okay. So with that as background, let's just run through some of the manifestations. They're all different kinds of rashes in lupus, and we subdivide them into acute cutaneous, subacute cutaneous, and chronic cutaneous. The picture on the left is that first case. Person goes out in the sun, they go down to Jones Beach, and they get this red rash, and that will go away on its own. Just get out of the sun. The one on the right is a little different. That's discoid lupus, or chronic cutaneous. And all of this rash can scar. And you can see actually hyperpigmented areas and hypopigmented areas. When it occurs in the scalp, there's permanent hair loss. This rash has a predilection for the ears, but it really can develop on any part of the body. Next. This is subacute cutaneous, and it can take on two different appearances. On the left, it kind of looks like psoriasis, so we refer to that as the psoriaform form of subacute cutaneous. And the one on the right kind of looks like ringworm, except there are a lot of circles. So two different types of subacute cutaneous. But there are other types of rashes in lupus. These are the major types. Next. Hair loss is very common. It can occur when the disease is very active. It can occur as a result of taking high doses of steroids. It can occur because of taking chemotherapy for lupus. But it can also occur when there's rash in the scalp, like the discoid rash that I showed you. And when that causes scarring, there's permanent hair loss. Next slide. Oral or nasal ulcers also are pretty common. These classically occur up on the palate, but they can occur on the buccal mucosa and on the tongue. They're typically painless, but not always. Next. Click again. Raynaud's. Raynaud's can occur without having any underlying disease. It's actually pretty common. But we will see Raynaud's in our patients with rheumatic diseases. Reversible vasospasm of small arteries in the fingers or in the toes. And this can be found certainly in lupus. Next. That's to be contrasted with vasculitis, which is inflammation of the blood vessels. And when there's inflammation of a blood vessel, you can actually have a blood clot. So there's a thrombosis, which means that there's no blood supply beyond that occlusion. And that's what you see here, vasculitis. This is very different than Raynaud's. In Raynaud's, the vessel opens up again. In vasculitis, it doesn't, typically. Next. And arthritis is very common. There are several different types of arthritis. This is actually called Jacquet's arthropathy, and it's a reducible deformity, meaning with a little bit of pressure you can straighten out the deformity. So it's a lot different than rheumatoid arthritis, where there's erosion, where there's destruction. Here you just have very lax joints, and if you look very carefully, you don't see the erosive changes like we do in rheumatoid arthritis. Next. The heart can be involved. All parts of the heart can be involved. The classic involvement is on the heart valve, what we call Liebman-Sachs endocarditis. And here you see the vegetation on the valve. Next. This is a patient of mine who is very interesting. I met her many years ago. She was in a car accident on the Long Island Expressway, came into the emergency room, and she was perfectly healthy. She came into the emergency room, and they did some blood tests, and they noticed that her platelet count was a little bit low. So they sent off more blood tests, and her ANA was positive, so they sent her to me. And she's telling me this story about the car accident and going to the ER. And I go, "What's with your arm?" She goes, "I don't know. For the last couple of weeks, it's had a mind of its own." And to make a very long story short, she had a complication of lupus. She didn't know she had lupus. That diagnosis was made. The hints were her low platelet count, the positive ANA, and she had chorea, spontaneous movements of an extremity, and we documented very nicely on this PET scan a hypermetabolic area in her brain when she had right hemichorea, and then it went away, and it came back. It was the craziest thing. It came back about 6 months later on the other side of her body. And that was a long time ago, and I actually still follow her, and she's done fine. Next. So the brain can be involved. There's about 20 different types of complications in the nervous system. This is immunofluorescence of a kidney biopsy. Kidney disease is pretty common in lupus. About 40 to 50% of patients will have kidney disease at some point in time, and that's a very serious complication. Next. Now, we use a lot of medications that are potentially toxic, one including steroids. Steroids have been the mainstay of treatment for lupus. One of the complications of high doses of steroids, the effect on the bones. And here is osteonecrosis, also known as aseptic or avascular necrosis. And basically the bone dies. And you have a misshapen femoral head, better seen on the next slide. So that's the head, and you see basically dead bone. We don't understand why it happens, but it happens. And we're talking about a young population who has to go for a hip replacement at age 25 to 30. Next slide. All right, so how do we make the diagnosis? Really the old-fashioned way, which means talking to patients. And I find a lot of doctors don't like to talk to patients anymore. They're too busy on the electronic medical record, right? I don't use the EMR. I scribble notes on paper the old-fashioned way, and at the end of the day, I sit there and I put everything into the EMR. So you talk to the patient, you're looking for certain clues like fever, hair loss, joint pain, rashes. You examine the patient, and then we'll check labs. And you heard about some of these labs. The ANA, which I'll show you in a second. There are yet other antibodies that we see in lupus. And then we look for abnormalities in blood counts, in the white blood cells, the platelets, the red cells, and of course we want to look at kidney function. Now there are classification criteria for lupus, and we don't really use those in day-to-day management of patients. It's more for studies, so that if I enter a patient into a study in New York, they meet the criteria just like the patient in Los Angeles. So the yellow ones are some of the criteria, the classification criteria. There are actually 11 criteria, and a patient has to meet 4 out of the 11 to be classified as lupus. Click on the next one. And I'm not going to spend much time on this, but these are the classification criteria. And if you can read it from the back of the room, it covers the different kinds of rashes, the oral ulcers that we talked about, arthritis, and so forth. Next slide. And yet more. These are more laboratory-based criteria. Next. So as far as laboratory tests, these are some of the things that we might see in a lupus patient. A low white count, and particularly a low lymphocyte count. They're often anemic, and there are many different causes of anemia. A high sedimentation rate we heard about just a little bit ago. And if they have renal involvement, the classic finding for glomerulonephritis is proteinuria. So it's really important to look at the urine. And then autoantibodies. Next. This is the ANA that you've heard about, anti-nuclear antibody. This is a test that's overly sensitive, and it's not specific. So in day-to-day practice, what that means is we get a lot of referrals for patients who have their ANAs checked by their doctors and they're positive. Go see a rheumatologist because you have lupus. It is not the lupus test. So I tell patients all the time, it's not the lupus test. It's not like a pregnancy test. It's just a test that tells you, well, listen to the patient and maybe order more tests to try to figure out why the ANA is positive. But it's estimated that there are about 45 million people in the United States who are healthy but have a positive ANA. It's done by a technique called immunofluorescence, and you're kind of held hostage to the technician who's looking at through the microscope, looking at these different patterns and colors and comparing them to controls. And the display is typically a titer. So they'll screen at 1 to 80, and if that's positive, they'll dilute the blood out twofold until it's no longer positive. But since proteins like to stick non-specifically to things, we often see low positives in healthy patients. These are all the different classic patterns, but a positive ANA, click on the next, tells us listen to the patient and send off yet more tests that carry a lot more weight if positive. So DNA antibodies are not seen in healthy people. You might see very low levels in psoriasis, autoimmune hepatitis, but they're really very specific for lupus. Hence, they are a criterion for lupus. And you have some other antibodies that are very specific for lupus, like Smith, SM, and some of these others. So there's not a single test that makes for a diagnosis of lupus. You have to put the whole picture together. Next. All right, let's just we'll talk about therapy. The goals of therapy are very basic, and it's no different in any other condition. Do good, do no harm. So what I mean by do good is to control the disease activity. We know that lupus disease activity begets damage. And the name of the game is to prevent damage, either from the disease itself or from the medications used to control the disease activity. And then do no harm, the medicines have the potential to cause damage themselves. Next slide. So the way we do it, we identify the disease manifestations, and I'll make a mental list. And it's so key in designing therapy to distinguish activity from chronicity. And what I mean by that, you could have a patient with rash, like that discoid rash that I showed you. When the discoid rash is no longer active, there may still be abnormal skin, meaning there might be hair loss in that area, there could be areas of hyperpigmentation or hypopigmentation, but it's not active versus an active rash. Or in the kidney, when a patient has proteinuria and hematuria, does that mean they have active lupus nephritis, or does that just mean they may have had active lupus nephritis in the past, and what we're seeing now with the proteinuria and the hematuria is the result of prior inflammation? It's now damage. So it's very important, and it's not so easy to distinguish activity from chronicity, and sometimes they're mixed together. So that's very important because you want to make a list of the active manifestations. No matter how hard you bombard a patient, you can't reverse damage. The definition of damage is that it's irreversible. So you prioritize on this, and you also have to remember that disease activity is a continuum, meaning you have patients with a little bit of rash, you have patients with head to toe severe rash, and everything in between. So the kind of treatment that you give for the mild rash may be very different than for the major rash. Next. And the obvious goal is to use the least toxic medicine in the lowest dose that controls that particular manifestation, meaning the number one manifestation, and assume that all the lesser manifestations will come under control with that particular medication. And that's where I think the art of medicine comes in as opposed to science. And we really wouldn't be talking about this if these medications didn't have toxicities. But steroids, you're all familiar with steroids. I mean, that was the greatest thing to introduce steroids in the late 40s. But they have side effects. Next. All right, so let's run through a case. Here's a patient who has swollen and painful finger joints, so she has arthritis, to the point that it's affecting her day-to-day function. She has severe pain in the right hip. It's from osteonecrosis and not arthritis. In fact, it's so bad the patient requires a cane to walk. So here's a nice distinction between the top one representing activity and the second one representing damage. All right, the patient on labs has hematuria, proteinuria, and also has high DNA antibodies and low complements. So that combination actually suggests active nephritis. The patient has marked hair loss to the point of using a wig. And then the platelet count comes in at a life-threatening value of 4,000. And then there's fatigue. Next slide. So if you ask the patient to rank the manifestations, you will most certainly get a different ranking than if you ask the doctor. So the patient's bothered by the hair loss, by the cosmetic effects of the hair loss, and by the fatigue. The arthritis, you know, I can get away with it, but she's much more concerned about the hair loss. The pain in the right hip, she's adapted to it, and she uses a cane. And numbers 5 and 6, she's not even aware of that because those are laboratory findings that the doctor found. So that's how the patient might prioritize those 6 things, with hair loss number 1. How would you prioritize things? Let's ask you that. What concerns you the most on this list? Platelet count doesn't bother you? Okay, well, here's how I would rank it. I disagree with you. Next slide. So this is the physician's priorities. The platelet count, 4,000, is life-threatening. Patient can have a spontaneous bleed from that.
But they may not know it.
No, but there's a distinction between the way the patient versus the doctor. And that's the point of this. So the platelet count being low is number 1. Nephritis is certainly potentially damaging to the kidney. However, you don't have to jump on that day 1, but a low platelet count you do because that patient could have a serious problem. Arthritis number 3, hair loss. There's not much we can do about hair loss. Again, it depends on the reason for it. Fatigue, it's a very common problem in lupus with not great answers, but it's not life-threatening. And then pain in the right hip, that's an example of damage. That's osteonecrosis. There's no medication that's going to bring that hip back. The only thing that could bring that hip back is a hip replacement.
Why is it the right hip?
And not the left one? It happens. Sometimes it happens to both. And often when you see it in one, it might be starting in the other one, as well as other joints. All right, so next. So how do we approach the treatment of a patient? Medications which we'll go through, but there's a role potentially, depending on manifestations, for physical therapy, for occupational therapy. Nutrition comes up a lot in questions, but there's really no answer there, just a sensible diet. But everybody's attracted to, I don't know what the latest fad is, that affects immune function. But there's really no good evidence for any of that. It's just an area that the NIH has not really supported. Psychosocial support, that is big, and it's neglected. Because doctors right now, you know, with the EMR, they're spending much more time. It was supposed to make our lives easier, but it's complicated our lives. So education of patients and the psychosocial aspects, I think, are being neglected. So who's taking care of that? Well, there are foundations like the Lupus Alliance of America is out here on Long Island. They have support groups and they provide education. But I think numbers 5 and 6 are being neglected probably in all.
And thank everybody for your patience. Doctor, whenever you're ready.
Okay, so we're just going to run through some of those groups of medications. Anti-inflammatories, they can be very effective for arthritis and for pain control. But be careful, they can have side effects, even though you can buy them over the counter. You can buy Motrin and Naprosyn and so forth. but they can cause kidney problems, liver problems, high blood pressure, bleeding, and so forth. All right, next. Kind of mentioned this, the anti-malarials, they've been around for a long time, and though we used to just prescribe them in lupus mainly for rash and arthritis, the teaching now is every lupus patient should be on this drug. It does have a dreaded side effect. It can cause loss of vision, but that's very rare. The drug can deposit in the back of the eye. Next. Steroids introduced in the late 40s, and they've been life-saving. They come in different forms, and they are life-saving, but they can have side effects when taken in high doses chronically. Next slide. So the side effects are related to the dose and the duration. So use the lowest dose that does the job. And a friend of mine, a colleague of mine down at Johns Hopkins, has a very extensive database. So she's able to do a lot of analyses of her 2,000 or so patients that she's followed for the last 30 years. So her teaching right now is that 6 milligrams of prednisone, which is not a particularly high dose at all, it's in fact a very low dose, is the threshold for where we see cardiovascular disease. So prednisone can cause cataracts and a whole bunch of other things, and we really didn't associate it with cardiovascular risk, but it is associated with cardiovascular risk, and that threshold is 6 milligrams. So it's so important. If the patient is doing well, keep lowering the dose of prednisone. Next. There are immunosuppressives or antimetabolites. The most popular one right now is mycophenolate mofetil, brand name Cellcept. It was introduced for the transplant population. Patients who are getting kidney transplants went on mycophenolate. It was far better than its predecessor, azathioprine or Imuran. And so we're using this now in lupus nephritis, and we're also using it for extrarenal manifestations as well. Next. Some of the potential side effects. I mean, when you start tampering with Mother Nature in some fashion, expect side effects. So we see, I mean, the major problems that we run into in lupus, infections, and it's usually not from the disease itself, it's from the medication, the steroids and these immunosuppressives. And then long-term, increased cardiovascular risk. Next. And then there's chemotherapy in the form of cyclophosphamide. We're not talking about the high doses that are used for cancer treatment. We're talking about lowish doses just to subdue that overactive immune system. And this has been the treatment, or was the treatment of choice up until many years ago for lupus kidney disease. Now we like mycophenolate. Next. These are some of the problems with cyclophosphamide, and this is why we stay away from cyclophosphamide. The infections, the sterility risk, so it kills cells in the ovaries, cancer. All these alkylating agents can cause cancer. So we really don't like to use this drug. Next. And then an introduction for lupus about 6 years ago was a drug called, belimumab, brand name Benlysta. And this was revolutionary because we started doing clinical trials looking for new therapies in lupus about 25 years ago or so. And it's been a really tough road. Nearly every study that we've done failed for a variety of reasons. But this was the first one to actually succeed. There were 2 phase 3 studies. The drug got approved. It's basically a monoclonal antibody against one of those growth factors that I showed you. It's a growth factor for B cells. So in giving this antibody, you starve the B cells of an essential growth factor, and their function actually declines over time. Another drug which actually failed in trials, but we still believe in, is rituximab, and that's an antibody that rids the body of B cells. So speaking to your question. But the studies failed, and when a study fails, it's not necessarily the drug that fails, it's more the designer of the study. It's very difficult designing lupus studies. Next slide. So when you design a treatment regimen, what do you follow? Again, it's the old-fashioned way. You talk to the patient, see how their symptoms are, you examine them, and you do laboratory tests. And you'd like to see things getting better. However, it gets back to that discrimination between activity and chronicity. You cannot expect some damaged area to reverse with treatment. So that osteonecrosis, that painful hip, is not going to get better because of steroids or the fanciest new therapy for lupus. That's damage. And that's why I say much of this is art and not science. Next. And when conventional therapy fails, there are a few different options, but not many. And this is why we need better therapies for lupus. Next. We've actually come a long way. I have 3 different eras. The pre-steroid era, and what I have on this graph is the probability of survival. So patients with lupus can die. In fact, I've been out at North Shore 32 years or so, and I have a database myself, and I've lost about 115 patients.
Out of how many?
That's a good question. It's well over 1,000. Right. So if you go back to the pre-1948, before steroids came out, you can see the survival was not particularly good, maybe 50% survival at 5 years after diagnosis. Causes of death mainly related to kidney disease. And then steroids were introduced, and you can see the survival rate actually improves. And then with the introduction of drugs like azathioprine and cyclophosphamide, you see yet more improvement. But what we really want is 100% to be perfectly horizontal. So we have a ways to go there. Next slide. So we need safer therapies. We need more effective therapies. We want to get rid of steroids. We want to get rid of the potent immunosuppressive medicines. We want to improve quality of life, prevent flares because it's the flares that cause damage. And we really need a cure for all of these autoimmune diseases. Next slide. So how do we do that? We do a lot of clinical research in our program, not just for lupus, but all the different autoimmune diseases. So a clinical trial is basically the way a drug gets approved. It starts with an idea in the laboratory, some way to interfere with the immune system in a very targeted fashion, and then it advances through animals into people, and there are different phases of development in humans, phase 1, 2, and 3. And phase 3, we're talking about large studies, maybe 500 to 600 patients, focusing on efficacy and safety. The FDA requires 2 phase 3 trials for drug approval. And if those 2 phase 3 studies are successful, then the drug gets approved. And then there's some post-marketing studies that can be done. It's just been a really tough road in lupus. We've had just 1 drug approved through this route, and I would say somewhere about 50 to 75 attempts. Next. But that's not been the case with our brethren autoimmune diseases. And you can tell this by just watching television, right? You see the ads for all of these different drugs, but it's not lupus. It's rheumatoid arthritis, it's psoriatic arthritis. So I would say there have been over 24 drugs approved for RA, for psoriatic disease, for inflammatory bowel disease, and so forth. But in lupus, we've just had 1. So we really need more drugs, safer drugs, more effective drugs. And one of the problems we're facing is a major reluctance by patients to go into clinical trials. The attitude is, You know, let the other person do that. But if everybody takes that attitude, then you'll never get a drug approved. So I encourage patients to talk to other patients who have been in studies or talk to the local foundation. And that's my last slide. So that's a whirlwind tour of lupus. Thanks.